no further ado, I'm going to introduce our speaker tonight. Jim Tate is the founder of EMR Advocate and one of the nation's leading experts on EHR certification and meaningful use. He's also a part of our virtual extension center, and we're thankful to have him. He's got a tremendous amount of experience. And if you ask a question and he doesn't know the answer and Roberta doesn't know the answer, nobody knows the answer, but we will find out what the answer is. And with that, I'm going to go ahead and I am going to turn this presentation over to Jim. And Jim, you can take it away whenever you're ready.
Great. Thank you so much, Carol. Carol, can you hear me okay?
I can hear you great.
Well, thank you. This is Jim Tate. I'm speaking to you from outside 7 o'clock Eastern Time, beautiful Asheville, North Carolina. If you've never come here, you should come here. We'd love to have you. I've been involved with the HITECH Act for, seems like it's been 20 years, but it's been 2 years now since the legislation passed. And for the first year, we were so focused on certified technology and what that all meant. And now we're getting down to the real detail since we have the certified technology, and we're trying to, everybody, hospitals, eligible providers, all stakeholders, try to make sense of the details of the meaningful use objectives. And tonight's the first in a series of a total of 5 webinars where we're going to examine each one of the meaningful use objectives in great detail. As has been the case the last 2 years, as this legislation has been defined and has matured, there is an ongoing amount of clarification that comes from CMS. Nobody has gotten any of the Medicare EHR incentive money yet. Some people have already received the Medicaid. So there are, since nobody's been down this road before, we're all just doing the best to interpret the guidelines moving forward based on real-world experience and guidance from CMS and ONC. Tonight, we want to examine 5 of the meaningful use objectives, in particular, 7, in particular, the ones that relate to drugs, medications, and e-prescribing for eligible professionals. This makes up 5 of the core meaningful use objectives and 2 of the menu set of the objectives. Just a little bit of background here. For eligible providers for stage 1, there are 25 meaningful use objectives, 15 in the core set, 10 in the menu set. And of the 25 objectives, they break down into 5 general categories. There are a number of objectives that are particularly focused on improving quality, safety, efficiency, and reducing healthcare delivery disparities. There are a number of objectives based on the ability to engage patients and families in their health care. We'll go into the details of those in a few minutes, but the ability to communicate and provide health records and exchange health records would fall in that category. The objective grouping to ensure privacy and security for personal health information. Number of objectives focus on the improvement of care coordination, not only within a particular provider setting, but across providers and the whole healthcare delivery spectrum. And then 2 or 3 that are based strictly on improving population and public health. We'll talk about those as we move forward here just a little bit. As I mentioned, there are 15 of the core set objectives, a total of 25 meaningful use objectives, 15 make up the core set. And on face value, we're told that eligible providers must meet all core objectives to qualify the incentive payments. We'll see a little later on this evening that some of these core sets can be excluded. So even though we're told that the requirements are based on meeting all these objectives in the core set, that's not necessarily the truth. And there are allowable exceptions and exclusions, and we'll look at those in detail. Beyond the 15 core set, there is a menu set of 10 objectives. And as part, I believe, as part of the attempt by CMS and Office of National Coordinator and HHS to gain buy-in from the healthcare delivery entities of this country, they wanted to make stage 1 doable. And to make stage 1 doable, they wanted to provide flexibility in what was required in terms of certified technology and the actual demonstration of meaningful use of that certified technology to make sure that the majority of providers and hospitals could be eligible for the incentives. So there's some flexibility here. Example of that is in the 10 menu set objectives, 5 of those can be deferred. So there's 5, we can defer 5, so I only have to do a total of 5 maximum. But as we'll find out soon with those 15 core and then 5 of the ones that have not been deferred in the menu set, that sounds like we need to do 20, but quite a few of these can still be excluded, especially in stage 1. As we look at each one of the meaningful use objectives, we're going to look at them at each one from 1 to 3 viewpoints. The objective itself, what measures are necessary to meet that objective, and possible exclusions. I've been involved with the certification of EHRs over the past 5 years, and in the last 6 months I've probably been through 30 or 40 stage 1 meaningful use certifications, and I've seen how many of the certified modules and certified complete EHRs assist in one way or another to help generate these measurements so the provider will know exactly if they've reached a threshold on a particular objective. We'll talk to details of that in just a few minutes here. For each one of the objectives, there's an actual measurement. The majority of these are percentage-based. There are several that are basically just a yes or no. Have you done the objective or not? An example of that would be drug-to-drug or drug-to-allergy interactions. There's no situation where the requirements are you must do that at least 30% of the time. You have to do it all the time. So it's either yes or no. In that case, the answer would be yes if you want to be eligible for the money. The majority of the measures are actually percentage-based with a numerator and denominator. And we'll look at how those are calculated as well as what the percentage thresholds are that are required by the CMS HR incentive program to make sure that those providers who are using certified technology are using them in a way that actually brings value. Just the possession of a certified EHR is not enough. We have to document in some way that it's being used enough to satisfy the government to obtain the incentives. I mentioned exclusions earlier. Some meaningful use objectives are not applicable to every provider's clinical practice. An example I would give is psychiatrists, being MDs, would be eligible, would be an eligible provider for Medicare, but they may not be performing vital signs. So that could possibly be a excludable objective for them. Or an eye doctor might not be performing immunizations. That could be excludable. So there are a number of exclusions that are available. And another point here that shows the flexibility of the system to try and make stage 1 meaningful use obtainable for the majority of eligible providers is that in the menu set where there are 10 objectives and we can defer 5 and are supposed to do 5, if we have some there that can be excluded, then those don't count against us. So quite possibly for some categories, and specifically specialists, in that menu set where they're supposed to do 5, if some of those can be deferred or excluded, they may still be eligible, only meeting possibly 2 or 3 of those objectives. Tonight, as I mentioned, we're going to talk about the objectives that are related to drugs and medication and e-prescribing. Over this 5 different presentations with question and answer, at the end we came up with a good way to kind of hopefully group these together. So the theme of the particular objectives kind of hangs together. In that case tonight, medications, drugs, and e-prescribing. Always a good idea to define some of the terms. And these definitions come straight from CMS. Definition of computerized provider order entry. This is the provider's use of computer assistance to directly enter medication orders from a computer or mobile device. As we look closer at the objective, we'll see that the actual threshold of what these orders have to look like and whether they have to be transmitted to an outside entity is actually very low. We'll look at the details of that in just a few minutes. The definition of a unique patient, this definitely needs to be defined. An example of why this is important to define is the requirement that a provider must provide certain types of educational material to patients. The actual threshold is during the reportable period, they must provide the educational material to at least 10% of their unique patients. So it doesn't matter if during that period of the reporting period for the incentives, if a patient came in 10 times and saw a provider, they would only be counted 1 time. So unique patient is very important, and we will see this theme of a unique patient, not a unique encounter, throughout a number of these objectives. Permissible prescriptions. When we look at the details of e-prescribing, this comes up, and a lot of questions have been asked about this over the last year. And when the denominator and numerator are generated to find out which prescriptions have been generated electronically or which have been generated by paper, the idea always comes up, well, what do we do about prescriptions that are written for controlled substances? Do they count? And so, because in many states, and the Justice Department has ruled on this recently, the ability to e-prescribe these medications, that definition has changed somewhat. So we wouldn't want these prescriptions to be counted in a denominator that would count against the ultimate percentage for a particular provider. Prescription authorization by eligible professional to a pharmacist to dispense a drug that the pharmacist could not dispense without such authorization. I'm not talking about over-the-counter medication here. Active medication list, that would be a list in the EHR of a patient's current medications. Also have to have a active medication allergy list. This is not an allergy list. This is a medication allergy list. It does not have to include food allergies, environmental allergies, those type of allergies, or contact allergies. Definitely a step of allergy, exaggerated immune response reaction to substances are generally not harmful. Medication reconciliation, just a couple more definitions here. Bear with me because we'll be getting to the details of these shortly. It helps to know exactly how they're defined. Medication reconciliation is identifying the most accurate list of medications the patient is taking in detail and comparing that with another list of medications that comes from the patient, hospital, another provider, or some other outside source. So this really is, for medication reconciliation, the comparison of 2 medication lists, one of which is the patient's active list in the EHR. Relevant encounter, encounter in which medication reconciliation is done because there's a new medication added or there's been a long period of time between a patient visit, or really for any reason that an eligible provider believes it's a relevant encounter and medication reconciliation must be done. Also, transition of care. Medication reconciliation should be done when a provider is the recipient on the receiving side of a transition of care, patient coming back from the hospital, patient coming back from long-term care, from a specialist or for some other entity. When they've been somewhere else receiving care and they come back to you, that would be that transition of care. Okay, let's talk about the actual objectives now, get into the details of it. One of the primary core objectives that we're told that must be met, the 15 core objectives, is the use of computerized provider order entry. Now, interestingly enough, for the EHRs to be certified, they have to demonstrate for this step that orders can be entered for medications, X-ray or imaging studies, or for laboratories, lab tests. But from the standpoint of the meaningful use, what the eligible provider must demonstrate is that we have to demonstrate that more than 30% of all unique patients with at least one medication in their medication list has at least one medication order that had been entered using CPOE. Okay, what does that mean? Well, that means that if we are looking, if an eligible provider is looking at a 9-day period of time, the denominator would be how many patients have been seen, unique patients, who have at least something in the medication list. They have some medication there. The numerator would be how many of those patients have had at least one medication order entered using CPOE. It has to be at least 30% or higher for a eligible provider to meet this objective. There's an exclusion here. Any provider, eligible provider who writes fewer than 100 prescriptions during the EHR reporting period can exclude this objective. Here again, kind of the details there, that denominator. At least unique patients with at least one medication in the medication list, numerator. At least one of those patients has had a medication order entered using CPOE. And we have the exclusions, as we just mentioned. And during the actual applying for the incentives, to apply for the exclusion, the eligible providers must enter the number of prescriptions actually written during the reporting period to attest that they can exclude, that's fewer than 100. Now, one interesting thing, the details of CPOE is where are these numbers going to come from? Let's just stop here and talk about this because this is very important. The denominator, number of unique patients with at least one medication in their medication list seen by the eligible provider during that EHR period. You would hope that that number is going to come directly out of your EHR, that in some way your certified EHR will be tracking that data or will provide some type of robust reporting function. So you can say that Dr. Jones, during this period of time, how many unique patients did he have with one medication for the denominator, and also be able to generate the exact data for that numerator and then calculate a percentage. That is ideally certainly what we want. However, the requirement, the certification for stage 1 requirement is not that EHRs generate this information automatically. Also acceptable is just manual input, meaning the physician has to keep a paper trail or some other way, or somebody in the office to keep track of these numbers to come up with a denominator and numerator. So depending on, just because EHR has been certified does not mean it's going to be easy to come up with these numbers. And if you can't come up with these numbers, then you're not going to be eligible for the incentives. Have to come up with numbers, and they have to meet a certain threshold. In this case, at least 30%. Additional information regarding CPOE. It's okay if the provider is permitted but not required to meet this 30% threshold, only those patients whose records are maintained using certified EHR technology. Some providers may see patients at 2 locations. Maybe in one area they're using certified EHR, another location it may not be certified, or they may still be paper-based at another location. So it's okay that the numbers, the numerator and denominator, are based on where those records that are being used for certified technology. The orders that go in for medication, this is not e-prescribing. This is the actual orders going in, where it's just documenting the chart that the doctor or some other individual that can legally order a medication order based on state, local, professional guidelines has been put into the EHR. It doesn't necessarily mean that it has been prescribed, just that an order has been put in into the system. Also, the CMS guidance says that this order must be entered by somebody who can exercise clinical judgment in case there are any clinical decision support rules and alerts that are generated during that input. Also, a little more guidance from CMS that the electronic transmittal of medication order is not a requirement for meeting this objective. As I was saying, this is not e-prescribing. This is just entering that order into the system. Next core objective, interaction checking. The objective here is to implement real-time drug-to-drug and drug allergy interaction checking. The measure here is that this functionality is enabled for the entire reporting period. So if in 2012, if an eligible provider, if that's their entire reporting period for the entire year, then this functionality, their EHR, must be turned on all the time. It's not a yes or no. It must be turned on all the time. And there are no exclusions. There's no way around this. This must be met. Right. Must attest to that for the entire length of the reporting period. Again, as we've discussed at other times, the first year under the Medicare program, meaningful use only with certified technology is only required for 90 consecutive business days. After that initial year, it's got to be for the entire year. So whether it's your initial 90-day period or its subsequent years, this interaction checking must be turned on and must be kept on. Next core objective is e-prescribing. E-prescribing is the ability to transmit permissible prescriptions electronically. This is not faxing. This is not e-faxing or electronically faxing out of the EHR. This is actually sending prescriptions. There's a certain type of prescription message over the computer networks directly to a pharmacy. The requirement here is that more than 40% of all permissible prescriptions, and of course that goes back to the definition we talked earlier about control medications, but for the permissible prescriptions that are written, at least 40% must be transmitted electronically. So only exclusion is if an eligible provider writes fewer than 100 prescriptions during the EHR reporting period. In the initial year, again, if the reporting period is only 90 consecutive days, if they don't write many prescriptions or fewer than one a day, then they could very easily exclude this. In subsequent years, where they're having to meet this objective the entire year, if they even wrote 2 prescriptions a year, they would not be able to exclude it because they'd be over 100 prescriptions. Interestingly enough, even if you can, if an eligible provider can exclude a meaningful use objective, they still have to have a certified technology to meet that objective. An example I would give here, possibly, well, radiologists might be a good example who may not be very involved with direct patient care, but are maybe possibly more involved with radiographic interpretation and analysis, may see very few patients, may never write prescriptions. And so they could exclude this and not have to meet this core objective. However, they still have to have certified technology that will allow them to e-prescribe. So we get a pass on the ability to actually meet the core objective or the menu objective, but we still have to have the underlying certified technology. This is kind of an interesting aspect here, the attestation requirements. Again, let's take it for 90 days. The denominator is the number of prescriptions that were written for drugs requiring a prescription. So let's say that a provider wrote 100 prescriptions. That'd be the denominator. The numerator, if they sent 40 of these electronically, then, well, let's say they sent 41 of these electronically, then they would be at that threshold. They would cross the threshold. They'd be at 41%, and they would meet this measure. The wild card in here is those prescriptions that they're not sending electronically. How are they going to know how many they've sent? There must either be some type of log or some workflow established to track prescriptions that are not sent electronically. They've got to be counted somehow to come up with that denominator of the entire number of permissible prescriptions that were written. The easiest way to meet this is just do all prescriptions electronically, all permissible prescriptions electronically, and then your percentage would be 100% all the time. If you're not going to do that, then you have to come up with some type of workflow to keep track of those non-e-prescribing orders. Again, some more information kind of goes across a number of these objectives here. Providers permitted but not required to limit the measure of this objective to those patients whose records are under the certified EHR technology. Discussed that a few minutes ago. And authorizations for items like durable medical equipment where orders are written. Wheelchairs, different infusions, oxygen concentrators, those kind of things. Those are also excluded from the numerator and denominator. In those instances where patients specifically request a paper prescription, sometimes you have patients who come in and they want a prescription written, a paper prescription, they want it in their hand when they leave. They cannot be excluded from the denominator of this measure. They have to be counted as a denominator. So somebody's got to keep track of that. And the final information is also that this recent guidelines from the Department of Justice allow e-prescribing of some controlled substance, but that has not been incorporated into the EHR incentive programs. E-prescribing has been part of federal incentives for a number of years. And moving forward, eligible providers cannot double dip and receive payments for e-prescribing under the old e-prescribing incentives as well as for the new EHR incentive program. However, it is interesting that under Medicaid, that double dipping is allowed. You can receive incentive payments for the EHR incentive program as well as the established e-prescribing incentive program that's gone on for a couple of years and has not lapsed yet. Let's go ahead and skip on to the next one. The purpose is just some more details here about e-faxing and electronically transmitting internally. And since this presentation is going to be recorded at the HITECH Answer site, you can kind of go back and look at the details if you want to, or send us a question about it. But just in the interest of time, I want to kind of move on and make sure I cover everything in detail. I want to make sure we catch all these objectives tonight. Another core objective is the medication list. There is a requirement that we maintain an active medication list. There has to be something in that medication list. They want to make sure that we're not only, to get the incentives, not only have purchased or somehow obtained certified technology that has a medication list, the government, to give incentives, wants to make sure that it's actually being used and there's something there. And so more than 80% of all unique patients, that phrase again, unique patients, during that reporting period seen by the eligible provider have at least one entry or that there's a medication there or some type of structured data or indication that the patient is not on any medication. And essentially they're saying that they want to make sure that with at least 80% of patients, somebody in that office with that certified EHR is putting something in that medication list, even if it is that the patient's on no medications. And no exclusions to this objective at all. Again, that denominator, unique patients seen by the provider during the reporting period, and the numerator is those who've had a medication recorded or indication no medications being taken. Had to be 80% or more. And I want to mention again where these numbers are going to come from. To come up with this percentage, a practice or eligible provider is going to need to know the number of unique patients seen. So hopefully your certified EHR technology will come up with that number for you. It does not have to. There's no requirement for certified technology to come up with those numbers automatically. And then the numerator, the ability of the certified EHR to look through those 80 patients during that reporting period, go back and look and see if there's anything in the medication list or structured indicator that there are no medications. So if your system is not going to generate these numbers for you, then there's got to be some manual or other way to do it. And that sounds very difficult to me. Additional information, as I said, if there are no active meds, we still have the indication that there are no active meds. We can't just leave it blank. Interestingly enough, providers are not required to update this list at every contact with the patient. They're not trying to interfere with the way a provider practices medicine and runs a clinical encounter. It's up to that provider to use their clinical judgment to decide whether updating to the active medication list is warranted. Next core objective is the allergy list. As we said at the beginning, this is the medication allergy list. It's not a food allergy list. It's not an environmental allergy list. We can certainly have those, but those allergies are not part of the meaningful use objectives. And very similar to what we just saw with the medication list, more than 80% of all unique patients, starting to be a theme here, seen by the eligible provider during that reportable period, have at least one indication or structured indication the patient has no known medication allergies, and there are no exclusions whatsoever for this. Very similar denominator and numerator, and also 80%. They want to make sure that if they're going to give us these incentives to the eligible providers, that the medication allergy module is being used, at least with 80% of unique patients. Not even with 80% of encounters, just 80% of unique patients during the reporting period. Hate to be redundant, but again, where these numbers are going to come from, this numerator and denominator, I encourage you, if you haven't selected an EHR yet, and you're looking at EHRs, ask to be shown the how these meaningful use objectives, thresholds, numbers, and percentages are calculated, what type of support they're going to provide to help. We just covered these. Again, we have to have something in that medication allergy list, and we don't have to update it every time. We're now down to the menu objectives. Again, 15 core measures, 10 menu objectives, and the menu set, we can defer 5, so we have to do 5. One of these is drug checks or formulary checks. This is the ability to do drug formulary checking. Kind of falls in 2 categories. The requirement is either that we could, if a patient came in and we were going to order a medication, or even if we weren't going to order a medication, it'd be possible through the certified technology to, knowing the patient's insurance, to see if a particular medication is on their insurance-covered formulary, and possibly with copay amount or what tier it's at. So we have to have this functionality turned on for the entire time. If a provider, eligible professional, writes fewer than 100 prescriptions during that reporting period, again, the first year it could only be 90 days, subsequent years has to be the entire calendar year, then this could be excluded. They mentioned here one internal or external formulary. An external formulary would be the one that I described, where you're checking an insurance formulary of a particular patient to see if medication is on the formulary. An internal formulary we don't often see that too much in the ambulatory physician's office environment. This would be checking the medication against a preferred drug list. Might see that more in a hospital or clinic setting, something like that. So it's one or the other. And this is a straight attestation where we either say yes or no, or we exclude it. If we don't exclude this because we're doing more than 100 prescriptions, then this functionality has to be turned on. And again, just mention on this screen that it's either internally developed formulary or external formulary. The vast majority of cases, I think, we'll just see those insurance formularies. Next menu objective, this is from the menu set, medication reconciliation. Medication reconciliation, this is something that we run across a lot in the inpatient hospital environment. A patient comes to the hospital and they have their home medications and they're put on some new medications in the hospital. Sometimes reconciliation has to be done. And then when the patient leaves the hospital, we kind of shift them back over to their home medications and possibly some new additional medications. So that kind of medication reconciliation takes place. A little bit different in the ambulatory environment for eligible providers. Here the objective is that when a patient is received from another setting of care or provider of care and believes the encounter is relevant, should perform medication reconciliation. If you haven't seen the patient in a long time, or if the patient is coming out of rehab back to you, or is coming out of the hospital back to you, or has moved away, has come back, the eligible provider may say, you know what, this is a relevant encounter, and there should be medication reconciliation there. And so that transition of care, whether a particular encounter is a transition of care, is really up to the eligible provider. The measure is that at least 50% of those transition of care, as defined by the eligible provider, medication reconciliation takes place. The only exclusions would be when there almost would be an eligible provider who doesn't see patients, which there are some. But if you're not the recipient of any transition of care during the entire EHR reporting period, this could be excludable. Again, this is where I want to go back to the concept of where are these numbers going to come from. So if it's up to the provider to decide if a particular encounter was a transition, of care. They're coming from another healthcare environment or domain. Somehow that physician or that provider, that eligible provider, is going to have to track either through the system, EHR in some way, or paper-based in some way, somehow to keep track of how many transitions of care they have been on the receiving end of. And then the numerator would be how many of those transitions of care where medication reconciliation was performed. So I've seen certified EHRs require documentation with check boxes and pull-down menus and other ways that can, in some ways, kind of complicate the documentation of the encounter. But it's an attempt to gather the information on the front end, so you can run a report at the end of the year or into that 90-day period and come up with some real valid numbers that help you meet these thresholds. Because if we can't come up with these valid numerators and denominators to get valid percentages, there's going to be no way to apply for the incentives in a valid way at all. Again, only patients whose records are maintained with certified EHRs need to be included in the denominator for these transitions of care. The real hope is that when a transition of care takes place, that eligible provider should be the one who conducts that medication reconciliation, looks at the patient's current active medication list in the EHR, takes any information from the patient or discharge or from some other source, and actually performs that reconciliation, updates that record. Well, thank you very much. It went by for me pretty quickly. We've covered, I believe, 7 of the meaningful use objectives tonight. Carol or Roberta, y'all can correct me if I'm wrong. Could have gone into more detail, but I didn't want to overload you with too much. I think we've covered the basics as well as some of the challenges. To me, the biggest challenge is where are these numbers actually going to come from that providers and their practices have to report. I'd like to mention a few resources. I work for a lot of practices and EHR companies, and was looking for a book to help medical practices understand the basics of the CMS EHR incentive program. I couldn't find a manual, so I wrote one. It's called the Incentive Roadmap, and that's available at hightechcancers.net. And I've also become very involved working with the Virtual Extension Center, which is at hightechcancers.net. This is a free, meaningful use resource site. Many of the people who are on this webinar now have already joined that site, and the purpose of it is to disseminate webinars and information. Any information we don't have the answer for, we have pretty good contacts with CMS to get those answers. And then also, of course, the mothership, CMS website has a very broad portal that's been put up that has quite a bit of information. So with that being said, Carol, I'll turn it back over to you and see if we have some questions.
We do have some questions. No surprise. A reminder to everybody: use the chat box or the question tab at the top to ask a question. We'll try to get through as many as we can in the next 13 minutes. If we don't get to your question, you can access the Ask a Question, Find an Answer in the VEC, and we will get back to you. So I'm just going to dive right in and begin. So if you're ready, the first question is,
sure.
We are a private practice radiology office. For the exclusions, do we have to, well, hold on, let me backtrack. We are a private practice. They're a radiology office. For the exclusions, do we have to have EPrescribing to be certified? We write fewer than 100 prescriptions. I may have misunderstood what you meant by that exclusion, but still needing to have the ability to get certified.
Right. The answer for that is that even though an eligible provider has the ability to exclude a particular objective. They still must have what is defined as complete EHR technology, which means either a complete certified EHR or a collection of certified modules that would make up a complete EHR. So even if you can exclude e-prescribing because you don't e-prescribe, it is still a requirement that you have the certified technology to e-prescribe. This is true also, interestingly enough, chiropractors are eligible professionals. And most instances I'm aware of, they cannot legally prescribe medications. And so that can exclude it, but they still must possess certified technology to e-prescribe. So
right.
You really have to have a complete EHR or collection of modules that would make up a complete EHR.
Right. And you touched on this next question. Actually, you know, what happens with a script that the patient requests? Does that account against them?
You know, it does. It's interesting enough that if a patient requests a paper script, that counts in the denominator of number of prescriptions written. So,
right.
Yes, it certainly does.
So this next question is lengthy, so bear with me, but it relates
Sure.
to the core measure number 1 in CPOE.
Mm-hmm.
As a specialist, nearly 100% of my patients have medications in their active medical list, but I don't prescribe the majority of those medications. I do write more than 100 prescriptions. It should require that if patients with medications in the medication list specifically prescribed by the EP, more than 30% are entered using CPOE. As it stands, it suggests that I need to write a script, regardless of need, for 30% of patients that come in with an active medication list.
Let's see. So let's talk over the details of this just to make sure I understand it. The denominator for CPOE is, again, unique patients with at least one medication in the medication list. And the numerator is that there's at least one medication order during that period of time. Now, that medication order certainly does not have to be e-prescribing. I'm sorry, Carol, did the questioner say they wrote fewer than 100 prescriptions?
No, they write more than 100 prescriptions.
So they write more than 100 prescriptions.
They do.
And so, Roberta, could you weigh in on that? I'm not sure. I got my...
Actually, I did. The question is that he's saying that he needs to count in the alternate or the medications coming from a list from someone else. He only needs to be counting his own.
The last part of the question is, as it stands, the objective suggests that I need to write a script, regardless of need, for 30% of the patients that come in with an active medication list, or they're already on other medications prescribed by other physicians.
I'm not sure where he's getting that. It's 30% of the prescriptions that you prescribe yourself.
To the overall total.
To the overall total of what you have prescribed.
Of what you prescribe, right.
The medication list is just that you have to attest yes or no that you're correct, Jim, that you're attesting that you are asking if they're taking other medications in the instance that it's there's a reaction or, you know, that the prescriptions are only what you're writing, numerator and denominator.
Oh, right. That's for e-prescribing, but I believe, I'm sorry, I think we got a little confused here. We're just talking about CPOE.
We are talking about CPOE, that's right.
Okay.
Right, exactly right.
Okay. So this provider is writing fewer than 100, and so they're being excluded. But if they're writing more than that, actually, you know, the numerator here, the medication order, CPOE, does not actually have to be an e-prescription.
No, the medication order has nothing to do with the prescription. The medication, the CPOE, has everything to do with you are ordering a specific drug for a patient. It has nothing to do with prescribing it, actually e-prescribing it.
Correct.
Okay. Yeah, it's a great question. I think we'll copy that one and we'll put it into the FAQ with the answer.
Okay, great.
Yeah. Next question.
Sorry about that confusion.
Yeah, it was a three-part question. I should have prefaced it that way. How would radiologists implement drug-to-drug and drug-to-allergy interaction checks?
Well, they have how they would do it. Probably they would have certified technology, and so that and it would be turned on. And even though they may never e-prescribe, if they want to e-prescribe, and the patient was already on some medication active med list, the system would do drug-to-drug and drug-to-allergy checks on the spot, interaction checking in real time.
Okay.
So there's no requirement that it actually ever fires, because if you don't e-prescribe, it's probably never going to fire.
Right.
But the functionality has to be there, so it would fire.
Next question. To have a unique encounter, does this have to involve a prescription or medical reconciliation, or can just a follow-up visit without prescription qualify?
Ask that question again, please, Carol.
Yeah, it's a good one. Yeah.
I think that depends on the actual objective. That's a broad question.
It is a broad question.
For a lot, the unique encounter only if you actually look at the numerator denominator is saying you have to have a unique encounter. Your definition of a unique encounter, it only applies to the objective that is stating you have to have a unique encounter. Correct?
Yes, it is, and so this is one area of definition that CMS is still working out. There is a meaningful use objective we'll get to, I think, I don't know if it's tomorrow night or Thursday night, that has to do with giving a patient a clinical summary of an office visit. And the question is often asked, well, what if they come in 3 days in a row and see a different provider each day? And CMS says, well, they would consider that just one unique visit. And the last provider they saw in that series is the one that would have to would count them for being able to generate and deliver a clinical summary of the encounters.
Got it.
So there's some flexibility, and they're trying to work out these details for sure.
This is a great question, sort of related to the future. With the menu set, we can defer 5. How long are they deferred? Will we have to do them anyway, and when? Stage 2.
Yeah, right. I think, and Roberta, chime in if I'm wrong with this, but I think that they're pretty clear. Oh, they've said that they expect that by stage 2, certainly for the menu set, none of those will be deferred. I believe we'll certainly still have exclusions, don't you, Roberta? We'll still have exclusions for outside the scope.
That's
and
correct.
Populations.
Right.
Yeah, still have
right
exclusions.
Now, the current matrix, like we saw back a year ago on the stage 1, the current matrix is out for recommendation to HHS, O&C, and they, I think they have 1 or 2 deferring, but it has to do with things that might not be in place yet. You know, there's not going to be any deferring. Your whole get on board is in these 90 days. You know, get what you can and go with it, because stage 2 is going to be everything.
Right.
And they have added objectives. There's more than 25 on the next set.
Yes. Yeah. Yeah, they've been clear about that. There'll be more. I think stage one was all about obtaining buy-in from the vendors, from hospitals, from eligible providers, from everybody. Stage one is getting everybody on the boat. And stage
two is going away from the dock.
That's right.
Yep, I believe so. I think it's a way to describe
it. What's I know there's been scuttlebutt out there. What's the inside skinny as to when actual stage 2 will be released? The objectives.
Well, I've heard them say that it should be finalized by the end of this year.
That's what I heard too.
Yeah, in 2011.
Right now, they're on schedule just like they were stage 1. I don't see any delay in that either. Like I said, you can go out there right now, or you can go on to the VEC. You can see we have resources.
Yeah, we've got resources talking about that as well.
What's coming
Sure.
Too. Most EPs right now are so enthralled in trying to get stage 1 done that it's hard to look at stage 2.
Right.
I know, it really is. And before we sign off, let me say again, my concern, and coming from a clinical background of patient care and what it's like in a physician's office, is for more and more attention start being applied to how are we actually going to come up with these numbers for these thresholds. So we can say 30 or 50 or 80%. But if we're either going to have very sophisticated, elegant EHR, some of which will do it for us automatically, or else we're going to have some workflow to track these numbers for events that occur that our EHRs are not tracking. But we're going to need that data to apply for the incentives.
Just a reminder that
Carol, just to piggyback on that, because Jim and I have spent a lot of time talking about that specific thing, and me consulting with EPs, that you have to think long and hard of the energy, time consumption in putting into tracking things that aren't in the EHR. So why are you spending all this time logging and tracking numbers that are not in your EHR? Get up front of this and put everything in.
Right, right.
I mean, that's been my recommendation, and in the prerequisite to implementation, the time and energy you're spending tracking how many overall prescriptions you're writing by hand is deteriorating from you getting on board to actually using your EHR.
Back to this workflow issue, yeah.
Yeah, and that's the thing. If you come up, and these are the 7 really intense objectives that you have to do. That they're only saying you have to do 40 or 50%, but you know what? Look at your time and energy spent on what you would get 100%, and then you're already ready for stage 2. You don't have to worry about it.
We definitely started with the heavy hitters. It's like the rest of them you're going to be like, oh, gosh, well, that's a breeze.
Yeah, if you can do this, you're pretty home free.
Speaking of which, a reminder that the second part of this series is tomorrow at 7 p.m. as well, Eastern Standard Time. If I didn't get to your question, we will be posting these questions and the answers in the FAQ in the VAC, and so that's a great place to check. Jim, Roberta, thank you so much, and
thank you.
I will get your PowerPoint and the recording into the VAC tomorrow for viewing. Thanks again, everybody.